And Kevin, if you want to get going, that'd be great.
Great. Okay, I think I got it all selected there. Can you see my slides, Heidi, coming through?
Yeah, they look great. Thank you.
Good. Well, thanks everyone for joining us on this cold, almost snowy day. And I am Kevin Winthrop. I'm the medical consultant to Heidi and the crew at the State Health Division. And I know many of you and enjoy working with lots of you on cases as they come up. And you're always free to call me directly or go through Heidi, and I'm happy to give clinical advice as you need it on some of these cases. What I wanted to do today, Heidi and I have been thinking about shorter courses of TB treatment, as has everyone in the world, and I just wanted to highlight some of the short course regimens on the horizon that I assume we'll be switching to at some point. And go over some of the data behind them, and then answer any questions about them or give you my thoughts anyway. Also to give you some thoughts about extrapulmonary NTM or TB rather, and just show you some fun cases, but also to highlight some principles of treatment. So the quest to decrease the length of therapy has been ongoing for quite some time. Let me just say here. So this was one of the earlier attempts, and hold on, I need to get rid of the thing on the top that's blocking my slides. Okay, so this was really the first attempt. As you know, most TB is treated with 6 months, and RIPE is the usual regimen: rifampin, isoniazid, pyrazinamide, and ethambutol. So that we call it RIPE. Some people use H instead of I for the for isoniazid abbreviation. Some people use Z instead of P for the pyrazinamide abbreviation. But anyway, RIPE is rifampin, isoniazid, pyrazinamide, ethambutol. So we all know we do all four for 2 months, and then we usually just drop to INH and RIF for 4 months for pan-susceptible TB. So that's our standard regimen. This was the first attempt, really, or one of the first attempts to look at whether moxifloxacin or rifapentine could shorten the overall length of the regimen. So there's a variety of animal data, mostly mouse TB studies and others, showing that rifapentine, particularly higher dose rifapentine, that's 1,200 milligrams daily instead of 900 milligrams daily, that increases the mycobactericidal aspects of the regimen and could potentially shorten therapy. The animal data also suggests that in combination with moxi, that further enhances that. So that was the goal of this therapy. And they really randomized people with pan-susceptible TB to 3 groups: the control group, which was RIPE like usual for 6 months. And then the 2 experimental arms were rifampin, moxi, M is moxi, pyrazinamide, and ethambutol. I just came up with my own abbreviation, RMPE. That's what I'm calling it. So you do that for 2 months, and then you do 2 months of moxi and rifapentine at the regular dose. So we really replace INH here with moxi upfront and in the continuation phase. So one thing we're looking at here is whether moxi replacing INH is helpful, and then again looking at rifapentine. The second group, maybe the more exciting group. Well, less exciting because it was longer, but maybe had a higher chance of success because it was longer. But again, looking at whether we can get rid of INH and use the rifapentine. So replacing INH with moxifloxacin in the first 2 months. And then in the continuation phase, like above, instead of 2 months, but used for 4 months, it was moxi and rifapentine. And not like above, however, they used a higher dose rifapentine. So there was something exciting about that higher dose. And it's only in that arm. Okay, let me see if I can get this to advance. Okay, just to show you who they enrolled. There were a high degree of cavitary patients. So you can see the bottom arrow was none. About a third of the patients in each arm had no cavities. So 2/3 of patients had cavities. A lot of folks have been former smokers. The other blue arrow on top is just HIV positive. So to show you that they enrolled HIV negative and positive, and almost a third of the patients in each arm, or at least a quarter, in each arm were HIV positive. I don't know why this doesn't advance for me here. Let's see if that works. So the results were totally disappointing, in that 4-month regimen really was not equal to the control group. It failed non-inferiority. So you can see that the portion of patients with favorable outcomes, which if you notice in the TB trial literature the last 5 to 10 years, we've gone away from cure, we've gone away from culture conversion, we call it favorable outcomes. And favorable outcomes are generally what I just said to you. They're people that have clinically resolved, they have become culture negative for a prolonged time period, and they don't relapse for a certain amount of months after stopping therapy, depending on the trial. So that's the definition of favorable outcome. And you can see here that, if you want to just call it cure, that at 18 months, the proportion of people in the 4-month group that had a favorable outcome was much lower. It was about 12 or 13% lower than either the usual RIPE therapy or the 6-month therapy replacing INH. So the 6-month therapy with a high dose rifapentine and the moxie really didn't do anything for us over our standard therapy. So this was a bummer. And the real bummer too was the idea of the 4-month dream did not seem very achievable after this. And again, note that in the 4-month or in the 4-month regimen, that middle one, 2 months and 2 months, they did not use high dose rifapentine in that 2 months. They only used the regular dose rifapentine. And that turns out to be a big problem with this analysis, that probably the high dose would have done better. So we know that now because we have other studies, and this is really the study that came out earlier this year that most of you probably read or looked at or heard about. This was Susan Dorman's study looking at 4-month rifapentine regimens with or without moxifloxacin. So a little bit of very similar to the last study I showed you, but a couple important differences. So inclusion criteria, again, pan-sensitive TB, and they had to also have fluoroquinolone susceptibility, of course, because we were testing moxie in this study. They could have HIV, but they had to be not, severely immunosuppressed. They had to have a CD4 count of at least over 100, and they had to be almost an adult. They had to be over at least 12 years of age. They couldn't be that sick. This is typical of many trials. If they already had LFTs 3 times above baseline, or low platelets, or low, super low hemoglobin, they were excluded. They couldn't have extrapulmonary involvement. So again, these are only people with pulmonary TB and pulmonary TB only. And they couldn't have been previously treated, at least not in the last 6 months, and they were non-pregnant. So going forward, keep that in mind. Who is this regimen applicable for in the future? It's really going to pertain to people who are pulmonary only TB, and those that are non-pregnant. So design features, I think, that were important. They stratified by the site, and this was a global trial, and they stratified by cavity, yes or no. So meaning, the comparison regimens were divvied up in a proportional fashion between these factors. So if you were at a certain site, you had equal numbers of people on each regimen by site, and as well as by cavity status. So the primary outcome was a favorable outcome, and that favorable outcome was defined as being alive and culture negative at month 12. And again, this was a non-inferiority design. So they assessed 5,124 patients. Half of those patients were excluded, which I thought was really high. I looked high and low to understand what the reasons for those exclusions were, and I could not find them. Some obviously declined to participate, but the 2,000 that didn't meet eligibility criteria, I don't know why. Obviously, some of that had to do with the exclusion criteria I just showed you, but I'm not sure. I'm not sure of the details of that. But it's interesting that so many people weren't eligible. Now, here are the regimens that were divided up, that people were randomized to by site and by cavity status. So you have your control regimen, which is RIPE, which, like I told you, they've kind of changed the abbreviations here and use H for isoniazid and Z for pyrazinamide. But this is essentially RIPE 2 months of RIPE followed by 2 months of INH and rifampin, the usual 4 months INH rifampin, the usual 6-month therapy that we all know and work with for many years. Then you had 2 rifapentine arms. You had the rifapentine alone arm, which one might hypothesize wouldn't work very well compared, if you went off that last trial I showed you. But what they did here was they put rifapentine into basically RIPE. They replaced rifampin with rifapentine, and then otherwise it's the same regimen. So rather than using rifampin, which is short acting, as you know, they use rifapentine, which is a longer acting drug at high doses. So you're really getting really much higher rifamycin exposure with this regimen. And this was hoped to be successful as a 4-month regimen. So 2 months of RIPE using rifapentine, and then 2 months of INH and rifapentine at the high dose, mind you, a 1,200 milligram dose. So the decision was really made to go forward with the 1,200 milligram dose and ditch the 900 milligram dose that we're using in LTVI, for example. So the last arm, the most exciting arm, rifapentine and moxi. So exploring again this rifapentine moxi synergy that we see in preclinical models. And this was, again, high dose rifapentine, INH, pyrazinamide, and now we've replaced ethambutol with moxifloxacin. We all know moxi is much more active than ethambutol. Why not give it up front and see if we can improve killing? So that was the regimen the first 2 months, and then you drop back to a continuation phase of actually 3 drugs, the rifapentine and INH, and then we left moxi in there for an additional 2 months, or we didn't do it, they did it. It's a good idea. Those are your regimens. So you can see by this color-coded chart that I can't understand because I'm colorblind. But I think what it tells you is that this was a global trial, and there are a lot of people enrolled from all over the place. You can see quite a dominant enroller in South Africa, of course, being a hotbed of TB, in addition to a hotbed of COVID-19 variants, unfortunately. But you can see that a lot of countries were well represented here. There were very few participants from the US, 27. So mostly this was a African trial with some Southeast Asian contribution. So again, the characteristics of the people in the trial is pretty typical, pretty similar to what I showed you to the last trial, although much fewer HIV positive patients. They had much stricter requirements around HIV, and only 8% of each arm had HIV positive patients. Similar, however, to the prior trial in terms of cavitation, and you can see that about a quarter of the patients it was absent in. So about 3/4 of the patients had cavitary disease, similar to the prior study I mentioned to you. And I will mention also that this study, you had to be culture positive, but you actually had to be smear positive. So these are all smear positive patients. If they didn't have a smear result, that could be replaced with a NAT result if it was above a certain threshold, in which we would assume they'd be smear positive. But for the most part, almost all these people had smear positive TB. So they were highly infected. Most were cavitary, most were smear positive. So I think that's impressive when you step back and think about the design and the meaning of the results. So this was a non-inferiority trial. And so these are the results. And if you can see my clicker here, I don't know, can you see my clicker? Yeah. Just look at the top line, the intention to treat analysis, which is what we should be doing in the study. And with the rifapentine moxi group, 21% versus essentially the same percent. This is the percent with an unfavorable outcome. So it was very similar between two groups. And when they adjust for HIV and cavitation, that's what this little black box is on each of these variables. And these are a primary and secondary analysis, and we don't need to get into that. But as you go down these lines, you look at people who are microbiologically eligible, meaning they had microbiology to be included in that analysis. And these are people who followed the protocol. And you can see in the per protocol, meaning that people actually took the medicines and did everything right. there was really no sense that the moxi-rifapentine was better as compared to the control. But when you do the intention to treat, which is the way to really analyze this data, you see that no matter the HIV status or cavitary status, you see that the rifapentine and moxifloxacin is certainly non-inferior to the control arm. You see these very wide confidence intervals and the estimate about 0. So they showed in this study that the 4 months of rifapentine moxifloxacin was essentially non-equivalent to 6 months of RIPE. When they looked at the rifapentine arm alone, and remember that was, I'll just go back to show you, but so again, the rifapentine alone was this arm. So it was simply, replacing rifampin with rifapentine essentially. In that arm, we really see no difference. And in fact, the control group looked better. So it failed non-inferiority. It was not non-inferior, which isn't quite the same as saying the other arm's better. And that's a whole nother discussion worth several hours. But the point is it's not non-inferior. And the control arm is probably better. So simply replacing rifampin with rifapentine did not help at all. And that's what's shown here. You can see rifapentine in control. So unfortunately, that was also seen here. This is a better way to look at maybe the cumulative percentage with an unfavorable outcome. You can see the people who had unfavorable outcomes over the time period at year 1, 52 weeks after randomization. Control and rifapentine and moxi were quite similar. It was about 8%, 10%, and then rifapentine again was more like 14% in terms of the unfavorable outcome. So the conclusion of this trial was, in a fairly sick population in terms of disease burden or bacillary burden, a lot of these, you could argue that 4 months of rifapentine moxifloxacin is as successful as 6 months of RIPE. In terms of safety, you can see the first line here, grade 3 adverse event profile. So this means a certain level of severity for any type of adverse event. It was about the same in all the groups, about 18% or 19%, a little bit lower for the rifapentine alone group. If you look at any serious adverse events, which that's really what we care about as SAEs when we look at these trials, that by definition means you had an event that was serious enough to basically get you in the hospital or require some sort of extraordinary or non-usual measure, like not oral antibiotics, but IV antibiotics or, surgery or something like that to correct the event. And you can see that they were equally distributed between the groups. And actually, there's a sense here that maybe it was a little lower in the rifapentine groups, 4.4% versus 6.8%. And when you looked at deaths in the trial, very few people died, 0.8%, 0.4%, 0.5%. So very similar between the arms. In terms of more granularity around safety, thinking about liver issues, which is what we're always thinking about, you can see some sense that probably the rifapentine, moxifloxacin, and rifapentine alone arms were slightly safer. You see fewer people with severe ALT or AST elevations greater than 5 or 10, 1.9% versus 2.9%, 0.5 versus 1.1. So some sense that that maybe this is a safer regimen in terms of less hepatotoxicity. And in terms of more on safety, because I do think we have to talk about safety when we're considering this new regimen. The events reported were also really no different. Neutropenia, you can see across the board here about 5% per arm. Hepatitis, we looked at the LFTs, again, very similar. So I found this data very reassuring that there really wasn't a difference between these groups in terms of safety. The control arm had a slightly, a couple percent higher in terms of efficacy or favorable outcomes, but they were overall very similar. And last thing to show you about the trial is the subgroup analysis, because I think this is important. It really held that when you looked at all these different groups, the combination regimen, the rifapentine moxie, unlike the rifapentine alone, the rifapentine moxie regimen really was non-inferior in every subgroup, no matter the BMI, no matter the sex, no matter the HIV status, no matter the age or smoking history. And this was important. You can also see it in these other aspects of disease. The larger the cavity, still no difference between the groups. The grade of smear positivity, no difference. The amount of gene expert positivity, no difference. So, in the history of diabetes, no difference. So, this is really important. It means most of our patients, no matter what their bacillary burden is or whether they have diabetes, et cetera, they should be eligible for this regimen. And I don't see a group here that doesn't look like it in which it doesn't look like it performs well. Sorry, I gotta move this thing around. I don't know how to get rid of that. Okay, next. Hide. There you go. Figured out how to hide it. Okay. Just to show you the alternative regimen, the rifapentine regimen that I already told you didn't work as well. You can see that what drove the fact that it was inferior was the fact that it did not do as well in the HIV positive individuals. And it did not do as well in the males for some reason. Older people as well as current smokers. So there was some sense here that some of these subgroups have performed just fine, like females, for example, but certain groups of people, it just did not work as well. And that's where it really fell down among HIV positive and among males primarily. A few supplementary things to show you. We always care about time to culture conversion. How quick can you convert someone's culture? And we always think about in these trials that the quicker we can convert them, the better, right? Think about it from a public health standpoint. The quicker you can make them smear negative, the better. The quicker you can convert them, the better. They're less infectious. There's less probability for transmission. We also think the quicker that they get negative, then it implies that probably we don't need to treat them as longer. So we're always looking for these regimens that do this more quickly. You can see in this analysis that the rifapentine moxie group did seem to do this more quickly. You can see at 2 weeks, about double the percent, about 10%, or it was really 12% versus about half of that had converted to negative in liquid media. So this was important. When you look at the red arrows here, just at 8 weeks, you can see a difference. About 80% in the rifapentine group, moxie group was converted as compared to the 63% in the control group. Now, over time, of course, the control group will catch up. So at 12 weeks, you can see it's closing the gap and they're all about 90% at that point. But early on, you do see this improvement. So again, it implies that this might be a regimen we can get away with for a shorter time period, which was, of course, shown clinically. So what does 4 months do for us? It might make it easier to treat. Patients will likely probably be more excited to take 4 months of medicine as compared to 6. It's less DOT, it's less work for case managers. If it's just a safe or safer, there's not increased work there. There's always the cost of the medicines to consider. So, Heidi worked this up for us. You can see our standard regimen up above here roughly costs $700. And that's basically what it costs in terms of medicine. If you look at the pricing down below, which from a public health access standpoint, we can get the pricing down below. The pricing in the middle here is, I guess, Heidi weigh in, but I think that's just non-preferred customer pricing. Like if we wanted to go buy it for fun.
Right, yeah, yeah, that's what the state pays for it because we can't utilize the 340B program. So the counties can buy the TB drugs under 340B pricing, which is significantly cheaper, which is why we're trying to encourage the counties to buy the drugs and then we will reimburse you for them.
Yeah. So thanks, Heidi. So that obviously is a huge cost savings. It brings the price down, to just under double what the regular regimen costs. So it is going to be a little more expensive. Of course, you're talking about an extra, $600 here for I don't know how many cases, 70, 75 cases statewide per year. So, you'd have to see how your decreased staffing needs and resources in terms of DOT and actually manage these patients. Obviously, there's going to be some cost savings there. I would suspect that would outweigh or probably far outweigh the increased costs associated with the regimen. But that's something for us to figure out, and maybe that's a little project for someone at the county level to tell us how much they might save by going to a 4-month regimen. So that is pan-susceptible TB, and that's where we're headed. We're headed to the short course regimen for most patients, and we could talk more about that at the end. What about MDR TB? So I want to show you where we're headed there. I was on the MDR TB consult service. In fact, I helped start it with Sundri Mace. She and I, this was our charge under Jenny Flood years ago when I was a CDC TB officer and I was assigned to the state of California. So this was like 20 years ago. We started this consult service for the state of California, which ended up being really fun and I think successful in terms of helping a lot of counties treat some difficult cases, particularly in counties where there were no experts. At the time we were doing what we'd always done, 18 to 24 months of therapy, 6 months of an aminoglycosides, preferably IV amikacin, and really preferably 6 months post culture conversion. So, you were trying for 6 months at minimum. If they were tolerating things, you often drifted past that point if they hadn't converted their culture yet. Overall, you were really trying to treat someone, 15 months post culture conversion in total. So that kind of should be a separate bullet there. 6 to 9 months of amikacin included in an overall regimen that should go at least 15 months post culture conversion. So that meant most of these patients, you were arriving at an 18 to 24 month time horizon. So now there are new guidelines, and it's really just the last 5 years. We have a plethora of new data supporting the use of one old drug, clofazimine, another drug that's not that old, but it's not that young, linezolid, and then a much more brand new drug, bedaquiline. And when you can include all three of these drugs together in a regimen, it turns out you can significantly shorten the regimen, and you can probably get away without using the injectable, the IV aminoglycoside. Now, I will tell you, I'm going to show you the latest study and tell you where we're headed here. I will tell you that I like using IV amikacin. I use it all the time. And the way I use it, and we've developed ways to use it, it's very tolerable. There's not many side effects at all. And we dose it intermittently. We give it Monday, Wednesday, Friday. When you dose it daily, like a lot of people used to do, you wreck hearing, you wreck balance, you can wreck kidneys. When you dose it intermittently and you let people's trough go down to zero and hang out at zero for a while, not only do you not change the efficacy of the drug at all, in my opinion, you make it a lot safer. So you're able to give it for a lot longer. It is a hassle having a PICC line and getting the infusion. That is the big hassle for most patients. But amikacin kills TB, and it kills Mycobacterium of all kind reliably, and probably just as well, if not better, than any of the drugs I'm going to mention. So it is something I've relied on for years, and I have to say I think, I always wonder if I had MDR TB, if I would be willing to forego the IV amikacin, and but I would probably want it anyway, just for fun, for a few months in the right hands, because I know it works. anyway, that's my bias about aminoglycoside. And the newer guidelines are not favoring aminoglycosides, mainly because of the toxicity and the hassle associated with putting in a PICC line. So it makes a lot of sense to try to avoid these agents if it's possible, but in a lot of cases, it's not possible. You probably saw Payam Nahid's guidelines come out last year. These were in a long time in the making. They did not consider some of the newest data that I'm going to show you because that came out after these guidelines were published. They basically tell you about how to build an individualized treatment regimen. If you have these patients, I encourage you to call me or call Curry Center or some other person who has good experience with MDR-TB. Generally speaking, you want a fluoroquinolone. I often use Levaquin. I think it's better tolerated, but that's anecdotal. But it does have less QT effects than moxifloxacin. And I have so many patients on so many QT prolongating agents. It's best in my mind to put them on levofloxacin instead of moxi. There is data showing that they're equivalent in terms of MDR-TB outcomes. So I often drift to levofloxacin. They really talk about prioritizing the drugs I mentioned, bedaquiline, linezolid, and clofazimine. Where I do strongly disagree with the guidelines is their prioritization of cycloserine. That's what we used to call it because it does make people psycho. Cycloserine is, I had several patients commit suicide while on this drug. I mean, they weren't my patients, but they're patients we were consulting on when I was at the state of California. If you're going to use it, you really got to monitor people closely in terms of their drug level and screening them for depression and anxiety. It's a real deal. It can make people depressed and it can make them suicidal. So I personally see no reason to ever use that drug. I swore it off 20 years ago, but here it is in the guidelines. So that's my bias. If you don't have any other options, I think you should feel good about doing it, but make sure your patient feels good about it too, and you monitor them very closely. They then talk about step 4, amikacin or streptomycin, but really amikacin is favored. If you need to, you can put that in the regimen. And then, we have our other agents, PZA and ethambutol, which, used to be thought of as first-line drugs in MDR-TB because they're first-line drugs. They are, in my mind, still, if you need to use them, but it just turns out some of these other drugs are more active. And then they really talk about PAS and ethionamide. Some of our old standbys really shouldn't be used unless you're totally desperate. So most of the time we don't even need to get to them. I'd say sometimes I still reach for ethionamide, but in general, you probably don't need to use them in many of these cases. So there is a WHO short course therapy, which I'm not really going to talk about. There was a kanamycin, which is, similar to amikacin. They just reversed the A and the K and a few other things. But the kanamycin is active. It's probably more toxic than amikacin. But they did have a kanamycin-based 9 to 12-month regimen that some people qualified for that they started touting, probably 4 or 5 years ago. More recently, they have drifted towards the BPAL regimen, which I'm going to go through because that is the updated short course regimen. Not everyone is eligible for these regimens, and if you read their guidance closely, here's some of the things that have to be in line. Disseminated TB, no. Extrapulmonary TB, particularly in those with HIV, no. If they're immunosuppressed, you're probably drifting towards longer course regimens. We all know immunosuppressed patients can take longer to respond to therapies. So not a lot of people are eligible for the WHO regimen. And here, our guidelines basically said that they didn't include consideration of the BPAL regimen. But part of the consideration given in the WHO documents are, if you don't have access to longer term regimens, then you shouldn't do short term regimens. So in the US, where people have longer, or better access to longer term regimens, I'm not sure we're going to try to get away with treating most MDR-TB with 6 to 9 months. But but let's talk about BPAL, and then I guess we could have a discussion about whether we feel comfortable using it or not. So this is a 6-month regimen, and this is the newest regimen. It will become, I think, the preferred regimen from WHO, maybe CDC someday for the right people who are eligible for it or who can tolerate it. It's 6 months of bedaquiline, pretomanid, and linezolid. So pretomanid, I didn't really go into yet. That is a new drug. It is FDA approved. I've never used it. I don't know what the access is to it. Heidi, is that a drug we can even access?
I am not sure, actually. I think we can, but I'm not positive. I haven't looked into it that much either.
Yeah, I've never gotten desperate enough to ask for it, but it is in this new regimen. It is highly active. It works well with bedaquiline and with linezolid. Like I said, in preclinical models where they threw all these drugs together, and now in the human. So here's the regimen. Bedaquiline or Sirtro, is the standard dosing. It's 400 milligrams every day for 2 weeks. That's the loading dose. And then you go to, that shouldn't be 20. It's 200 milligrams 3 times a week. The pretomanid is 200 milligrams daily, and linezolid is 1,200 milligrams once daily. And when I saw the study, I think Heidi and I looked at the methods and I said, holy moly. I mean, no one in their right mind is going to take 1,200 milligrams of linezolid once daily. And I'll show you why in a second. I said, none of my patients will be willing to do that. That's what I said. So the outcome definitions of the study. So again, the primary outcome was a favorable outcome. And this was measured 6 months post-treatment. They had to be alive. They had to have clinical resolution disease, and they had to be culture negative. And so they, had to have had converted their culture, of course, which was defined as 2 consecutive negative cultures, at least 7 days apart. In a lot of these studies, they're getting monthly cultures. So the monthly cultures will often be, negative 4 weeks apart, and that will constitute culture conversion. Baseline characteristics of the patients, a couple things to point out: fairly young, 35 was the median age, about 50-50 male, female, a predominant Black individuals in the trial, a little bit low on the BMI side, 19.7. Half of these patients had HIV, although of high median CD4 cell counts. Cavities present, so no, only 16%. So of 109 individuals, and I should tell you, these are individuals with MDR or XDR. You had to have DR. You have to have at least MDR or XDR, somewhere in between. So these are people with really resistant disease, and a lot of them had cavities. You can only see, so 84% of people had cavitary disease, and 50% of these people had HIV. So this is pretty impressive. This is a tough group, I would imagine, to cure. So time to negative culture status according to the type of TB. So you can see the MDR and XDR track very well, and that even by here at 8 weeks, we had the majority of people had converted their cultures to negative. So really 75% of people by 8 weeks, no matter the type, had converted their culture. So you actually see in the first 2 to 4 weeks, you see a pretty substantial percentage of people converting culture. So at week 4, it's about 50%. So that's impressive. The efficacy analysis of the primary outcome, and again, the tension to treat analysis. And there's no regimen comparison groups here, right? This is descriptive, and it's open label. We're looking at people with these 2 highly recalcitrant disease types, XDR and MDR. And you can see that the percentage of patients with favorable outcomes is almost 90% in each group, 89% for XDR, 92% for MDR. That's unbelievable. I was shocked. This is really impressive data. The number of deaths were 7 overall, 6 in the XDR group. And what's really impressive is withdrawal during treatment. Almost nobody withdrew their treatment. I think probably because they were dying of drug-resistant TB and they didn't have a whole lot of other options. Because I can't imagine that, like I told Heidi when we talked about this 2 years ago or a year ago, I mean, my patients would not tolerate this regimen. So here's the data, the adverse event data. Linezolid at those doses is very hard to tolerate. You had 60% of people in each group roughly that had a grade 3 or 4 adverse event. 30% of people in the 600 milligram twice daily group had a serious adverse event. Linezolid is very difficult to tolerate. And I'll get into that in a second. So I want to tell you what was just reported about 3 weeks ago. So now they have the long-term follow-up data, which is even more impressive. So at 24 months after treatment completion, so they followed these people for additional 18 months after the primary outcome measure I just showed you. So at 24 months after completing therapy, they've only had one relapse. So the favorable outcome is still about 90%, it's 88% now. This is very impressive. So that means that, most of these patients were cured. And by our definition of cure, thinking it, no relapse in 24 months after treatment completion, they cured about 90% of these patients who were highly infected with high vascular burdens with the 6-month regimen. I will show you this though, at the completion and at really 2 years follow-up, still 10% still had peripheral neuropathy associated with their linezolid. So while that gets better over time after stopping the drug, it can be persistent. So what do I know about linezolid? We did a study a couple years ago looking at NTM patients treated with linezolid. And the percentage of people that drop off linezolid is really high. You can see here that 50% of people had to discontinue. Almost all of this was due to peripheral neuropathy by about 30 weeks into study. So, I guess that's about 6 months. And if I always figure I can get about 50% of my people to maintain their linezolid dosage through about 6 months. And that comes from this study. And that's about right. So I often don't use linezolid up front. I save it for a rainy day and I use it later. But it turns out it's so highly active, particularly in combination with bedaquiline and Clofaz. I think for MDR regimens, you really do got to dose it early and cross your fingers and hope people don't bail on it. So there is another trial. It's called the ZNIX trial. So that last trial was called the NIX TB trial. And so the ZNIX trial is just finishing up. And its goal was to keep the bedaquiline and the pretomanid dosing backbone, keep that going, but see if we can get away with lower doses of linezolid because we know we'll have less toxicity. So in terms of efficacy, they did the same trial, 6 months, but just with lower doses. And so you can see here that the dosing arms for linezolid were either 1,200 milligrams for 6 months or 1,200 milligrams only for the first 2 months. And then the other two groups were 600 milligrams, 6 months, 600 milligrams, 2 months. So pretty substantial dose decreases. When you go to 600 milligrams, we know linezolid is much better tolerated. What was interesting is the efficacy of this regimen really didn't change no matter how they changed linezolid. So clearly the first 2 months are important. The last 4 months are probably not as important. So if you wanted to pick a regimen here, maybe you'd say 600 milligrams, 6 months, maybe that's the winner in combination with bedaquiline and pretomanid. If you look at the toxicity, I think the data probably would also support that idea. You can see that, with the study, to finish this, you can just see that original regimen with the linezolid at 1,200 milligrams, 6 months, 38% had peripheral neuropathy, 22% developed anemia. So it's quite a toxic regimen, and a lot of people in the US wouldn't be accepting of this. And as I showed you, the peripheral neuropathy can take a long time to go away and can still even be present, 2 years after stopping the medicine. I think probably the winner is the 600 milligrams for 6 months, where your rates of peripheral neuropathy and anemia are substantially lower. And maybe even for the 2 months, there was not that much diminished efficacy in the 2 months of linezolid. So I think, we will be drifting towards a BPAL regimen that employs somewhere between 2 and 6 months of linezolid, and maybe even 2 months. But, probably you could play that based on how well they're tolerating it, right? And if they're tolerating it at 2 months, you can keep it going. If they develop peripheral neuropathy at 4 months, you might consider stopping it, for example. Okay, so those are short course regimens. I want to transition and just say a few things about fun extrapulmonary things. So I have a mystery case for you. 73-year-old Hispanic guy. This is actually a question I wrote for the ID board's board review course. And this guy was born in Mexico. So I'm immediately thinking he's got TB, fever, night sweats, 1 week, decreased appetite. So he comes from a place of TB incidents. He's got the right symptoms, constitutional symptoms. He was coughing actually too. That's not on here. Decreased appetite. What was interesting is he had a prosthetic aortic valve placed 2 years earlier. And what was also interesting is when he was referred to me, I found out he'd been getting BCG put into his bladder. So intravesicular bladder installations of BCG for his bladder cancer. He'd recently been down in Phoenix, tearing down a chicken house with his brother. So chickens always make you think of certain things. And when I examined him, he looked like he had TB. Like I said, he was febrile. Interestingly, already had elevated LFTs 2 to 3 times upper limit normal. And when we did a chest X-ray on him, he had all these tiny nodular lesions all over, little milia all through his lungs. So which of the following is the most likely diagnosis? And I don't know, we probably can't do like an audience response thing here. So could he have endocarditis? Sure, because he could be clicking off emboli all over the place, and that's what all the things in his lungs are. Could he have disseminated MAC? Absolutely. But he's not immunocompromised to our knowledge, so we wouldn't expect that. Could he have disseminated MTB? Absolutely. He has some TB risk factors in terms of where he was born. Could it be disseminated M. bovis infection? Either M. bovis from a natural TB infection, or perhaps even his BCG from his intravesicular installations. Or could he have disseminated histo from his chicken house work? Histo is not that prevalent down in Phoenix. I'd be more worried about coccidioidomycosis, but what the heck, maybe he's got histo. So the answer, of course, is this is M. bovis. This is BCG osis. And this is a classic picture of someone's bladder who's been getting intravesicular BCG treatments. You can see that the lining where these white arrows are, this is the lining of the bladder, is thickened and inflamed, meaning there's quite a lot of inflammation going there. There's an infection, and that's the whole point. When you put BCG in the bladder, you expect BCG to infect the lining of the bladder, and that the inflammatory response will then go ahead and kill the cancer cells that are there. So does this work? Yes, it does work. And people still do it to this day. So you do have this self-limited infection in the bladder itself, in the bladder wall. Now, sometimes that infection escapes the bladder wall, and you can see it go to regional lymph nodes, which aren't really shown up in the CT cut, but you can see it expand throughout the pelvis to lymph nodes. It can go to the epididymis. It can get into the bloodstream. And here's this guy's CT scan. He's got a miliary CT. This is all BCG-osis. So this is really BCG sepsis or disseminated BCG. I think one has to assume if their immune system allows this to happen, that probably they have it everywhere in their body. And it's even probably in their brain. So I treat these people for 12 months when I see them, because I assume it's all over the place. The first step is CTing them and finding out where it is. There are some people that just have regional lymphadenitis around the bladder. You don't need to treat them for 12 months. BCG is fairly benign, and it will get better with fairly benign therapy or less aggressive therapy. So sometimes when it's just around the bladder, I'll treat for 3 to 6 months, and anywhere in between, it's probably it's a 6 to 12 month deal depending on where it is. How common it is, it's not that common, but this was a study, 1992, which is a long time ago. It just shows you they've been doing this a long time for superficial bladder neoplasia. And you can see that about 9% of these people develop prostatitis, or I'm sorry, 0.9%, 0.17% pneumonitis. So, small percentage of people here, but overall, this adds up to, 1 to 2% of people who get BCG installed can have some extra bladder manifestation of infection. And you can see true BCGosis, which means it's everywhere. The sepsis is rather low, is only 0.4%. So my pearls, remember, it's PZA resistant, so there's no reason to use PZA. You can often just get away with INH, rifampin, and ethambutol. If it's really disseminated, like far reaching beyond the bladder or the area right outside the bladder, I often add a fluoroquinolone. You generally don't have to use an aminoglycoside, although I guess you could consider, if there's bone disease, giving them some IV amikacin, but I don't think I've ever done that. I've always just gotten away with oral therapy, and it should be responsive. I think the big thing to remember is the IGRA will be negative, and this guy, the IGRA was negative. But if the IGRA is positive, then you gotta worry that maybe you're dealing with TB. And that's something that you need to sort out with all these people, that, not just with IGRA, but with the microbiology in the lab. You want to see if this is M. bovis from the TB complex, or if it's M. bovis and it's BCG strain. So, obviously, if it's real TB, you're going to be potentially more aggressive, potentially treat longer. But in general, your treatment lengths are probably the same. I just know that I worry about them more if it's real TB, MTB complex as compared to BCG. So that's that. A couple other mentions about extrapulmonary TB. This is a woman who.
Hey, Kevin, could I just jump in for a second?
Yeah, sure.
Sure. I just wanted to mention that we do not count the scenario you just described. We don't count that as a TB case. So I just wanted people to know that wouldn't be counted as a TB case per the CDC definition, unfortunately.
Yeah, and it shouldn't be, because it's not technically an MTB complex case. It's BCG derived TB. So yeah, that's correct. And it could also happen too, I should say, in someone who's severely immunosuppressed, or a kid who gets a BCG vaccine and they're really immunosuppressed. You can see the same phenomenon, disseminated BCG from the vaccine. But of course, we don't see that in this country, since no one's using the vaccine. So that's good. So yeah, the last couple cases here, and then I'll finish up. This is a woman who had terrible osteoarthritis. She had a prosthesis put in, so she had a arthroplasty done. She felt a lot better. But about 3 months later, things started pussing out from her joint. She developed these nodules, which would drain pus. And eventually someone thought about it and cultured TB. So the questions were how long to treat it. And, considering it's bone and joint, 9 months, I think, is optimal. I extended her to 12 months simply because she had the orthopedic hardware. Unlike other mycobacterial infections where you have to remove the hardware, most of these cases you don't. You can leave the prostheses in and treat them. And it's simply because TB, unlike non-TB mycobacterium, TB is not really a big biofilm bug. Non-TB mycobacterium will find a biofilm on that hardware and inhabit it and never leave. And it's very hard to kill them unless you can debride the biofilm. TB, however, is not like that, and it's much more amenable to killing on these type of surfaces. So you often don't have to replace the hardware. You can leave it in, which is great for the patient. But I do treat them a little longer in 12 months. I have some mentions here about surgery as well. You usually don't have to do surgery unless something important is being threatened. So spinal TB, of course, you can have important structures being threatened. So we often drain things and do surgery. But like for this case, the knee case, like I mentioned, we didn't even have to open her back up and wash her out, although that was done because we were trying to make the diagnosis initially. So children under 5, lymphadenopathy, think NTM, that's the usual. But if they're under 5 or over 5 and they're from a TB endemic area, think TB. And this is just a real classic picture. All of you have seen this type of disease. 6 months of treatment is adequate. It's not unusual that somewhere during the 6 months or even after stopping, we have lymph nodes recur and they swell. And when they do that, I rebiopsy them or I excise them. It's often not culture positive, it's culture negative. I've seen these patients and it's just immune reconstitution like phenomenon. I don't retreat them. Sometimes I extend their therapy if this happens during therapy until I'm convinced that the infection is truly gone. But just to let you know, sometimes this happens. So it's interesting. And it may be that not all the bugs are cleared out of there and our cultures are negative. But if the cultures are repeatedly negative, then you got to think probably it's just an immune phenomenon. And then I'll just mention pericardial TB, adjunctive steroids. Yes, there was an RCT a couple of years ago that showed really no difference. So we often don't do it. But there is some individuals where it probably does help prevent constrictive pericarditis. So in general, you don't have to do it. But I think it depends. And if someone's got a lot of pericardial inflammation, big effusion, it depends how thickened things are. I think most of us still use adjunctive steroids because we do want to prevent constrictive pericarditis. The last thing I'll tell you about is renal TB. These are nice images. You can see the black arrows of renal abscesses and TB. This is also something we see alongside GU TB. I'm just showing you other spots where TB shows up. I mean, truthfully, TB can just show up anywhere. But I would say I don't see a whole lot of renal TB. I'm more likely to see GU TB. And this is usually, tubo-ovarian disease. Sometimes we need to do surgery if there's large abscesses. For renal TB, again, sometimes we need to do surgery if there's a hydronephrosis or renal failure. And then sometimes, of course, you need to adjust your doses here. I have if they're in renal failure. So generally speaking, though, most of these extrapulmonary forms, you can get away with 6 months of therapy. If they're immunosuppressed, sometimes you push it longer. If it's bone and joint, again, usually 9 months. If it's CNS, we talk about 12 months. Here's a tuberculous empyema that had to be, that's on the right here where this arrow is. That was a surgical case as well. Oftentimes, again, that's something that might necessitate surgery. But usually pleural TB heals up on its own. You don't need corticosteroids. That's an important point here. And again, the empyema, you end up surgically draining. Let's see what else. 12 months of therapy for tuberculous meningitis. I think I just mentioned that already. Sometimes we add a fluoroquinolone because of the better CNS penetration. Again, surgery if there's important structures that are being compromised. And then certainly dexamethasone with these individuals is very important. So this is really the one form of extrapulmonary TB that you really have to use corticosteroids. We often use them around the heart. As I mentioned, we often use them with ocular TB. There you go, speak of the devil. We see a lot of ocular TB, don't we, Heidi? Mainly because we have one of the best inflammatory eye divisions in the country or in North America at the KCI Institute here. So we get a lot of referrals from all over the West primarily. But I do think that's probably why we have a few more cases here than other places. Usually we treat for 12 months. Some of you see me maybe sometimes treat for 6 or 9 months. It's really restricted to the front part of the eye. Then we think of it less as a CNS issue. And we probably, we try to get away with shorter time periods of treatment. If it's in the back of the eye, the retina is involved, or the vitreous is involved, or choroid's involved, then we will extend the therapy. And this is an OCT, this is basically an ocular CT, and it's hard to understand this imaging, but this depression right here is the fovea. That is your central vision. And all what you see here layered out are different layers of the retina. And underneath here, you see this membrane, and you can see it's kind of bumpy, and you see this little bump here, and there's black right underneath it. That is a deposit of TB underneath the retina. that membrane should be nice and flat like it is out here. So you can see these little bumpies here, and those are essentially granulomas that have formed underneath the retina. And then my favorite case, I presented at ATS about 10 years ago, but this lady who was having recurrent epiphora, which means her eye keeps watering. After all was said and done, the reason for epiphora, once someone did a nasolacrimal duct scope, they stick a little scope between the corner of your eye down to your nose. They found this bump. There's a big granuloma there. They biopsied it, and turns out that was TB. Her TB reactivated in her nasolacrimal gland, which then caused her tears to back up and come out her eye, and that's why she had a watery eye. So, oh, and there it is. There's the granulomas that were seen and biopsied. So that's pretty cool. And then those are her cervical lymph nodes that the TB then drained to, and these eventually became enlarged and necrotic. So she reactivated in her nasolacrimal duct, drained to her cervical lymph nodes, and then ended up seeing me at some point. So I'll stop there. I've been talking long enough, and happy to take any questions, and want to thank all my collaborators and friends. So thanks.
Yeah, thank you, Kevin. Does anybody have questions for Dr. Winthrop? You can go ahead and take yourself off mute, or you can stick it in chat. Oh, I see one in chat there. Do you see it, Kevin?
Maybe. Let me see.
I can read it.
Yeah, if you could, that'd be great. I'm not sure. Oh, I see the chat there. Here, I can do it.
Okay.
Does use of vitamin B6 during treatment help peripheral neuropathy in this regimen? That's a good question. So we often give 100 milligrams of B6, and it turns out that probably actually helps anemia more than it helps the peripheral neuropathy. So, and to be honest, when that study I showed you where we looked at the NTM patients, we really saw no benefit of the 100 milligrams with either outcome. But I know there are other studies that have suggested a benefit, particularly with the anemia prevention with the B6. So I don't know that it helps with the peripheral neuropathy. I often, give a dose of B6 with these people. B6 is weird because if you have too much B6, you also get peripheral neuropathy. So go figure. Not enough and too much gives you the same outcome. So I guess you got to hit the sweet spot. But yeah, I think, with linezolid, it is pretty standard. We still give the 100 once a day. Any other questions or comments, in terms of drifting towards a short course regimen someday soon?
Does anybody have concerns about using the short course regimen?
Sounds like nobody's concerned about it. That's great.
It's not.
Is anyone excited about it? I'm excited about it. I think it'll be fun. And the nice thing is these are not expensive drugs. Oh, good. Lisa's very excited about it. Thanks, Lisa. I share your enthusiasm. They're not expensive drugs. The MDR TB stuff we'll have to talk about later in terms of how to afford some of those medicines. I mean, clofazimine is not available in the US, so we have to get it through a special access program, essentially from FDA in Europe. Bedaquiline is extremely expensive. And linezolid can also be fairly expensive. So those are things that I guess we'd have to work on at some point, getting access to those medicines. But I don't know, Heidi, if you have thoughts on that. But
I'm hoping people's insurance will cover them if we need it. We've had some luck with that with bedaquiline in the past, so
yeah,
that helps us.
Yep. No, and then actually bedaquiline, they have a compassionate use program. So even patients I have that can't get it through their insurance, usually we can get it through a compassionate use mechanism. So
yeah, we'll find a way for sure. Whatever we need, we'll find a way. Any other questions or comments? Oh, here's one. There's another thing in chat there.
Yeah, I think Lisa, you're probably right that case management services and staff time outweigh the drug costs. I mean, there's no question mine it will. I think the sell to patients is just also, that's important you bring that up. I mean, particularly with LTBI, right? I mean, the shorter course regimens are way easier to convince a patient to take than 9 months of INH. You know, for active TB is less of an issue. You don't usually have to sell it because the patients feel sick and they have TB and they want to be treated, but not always, as you know. I mean, you and we've all had cases that still you need to sell the idea of taking the treatment too. But I agree. I think it's easier to think about a shorter course than a longer. So.
Okay, any other questions? All right, if not, I guess we're done. You can always email me or Dr. Winthrop questions anytime. We're happy to help you. Thanks everybody for attending today.
Yeah, happy holidays, everyone. Nice to kind of see you, but we'll see you again.
Bye-bye.
See ya. Cheers.